All right, very good. Welcome all to Cardiogenic Shock and Mechanical Circulatory Support. Another day in Wonderful Wednesday. Today, of course, as all Wednesdays are cardiac focused, and I'm so grateful that you've joined here today. Thank you very much. I do want to let you know that there may be a patient urgency that I may need to head off to. Right now, it doesn't appear that way, but it may occur, and if so, hopefully we'll be done with our program, but if not, I'll need to close the program pretty quickly afterwards. So thank you for your tolerance. And so to begin with cardiogenic shock and MCS. So we're going to start first with a case study of a 62-year-old man who's brought to the emergency department. He has a sudden onset of chest pain. He has excessive sweating, nausea, and dyspnea, and very ill appearing. We're very concerned about him when we're looking at him. We don't know anything else about his medical history. No big surprise. That happens a lot when we see our patients. And he's very agitated. He's not able to tell us anything, but his vital signs are very telling. First of all, his respiratory rate is 40. Remember, whenever you see persistent tachycardia, always consider that a patient may have metabolic acidosis, and always consider that until proven otherwise. So very important for us to appreciate that that may be the problem for our patient. The other thing that's important here is to look at his heart rate, which is tachycardia. Now, remember, tachycardia and tachypnea together typically are compensatory mechanisms for metabolic acidosis until proven otherwise. And in addition to that, of course, he's got hypotension. And by the way, his SAT is awful. His SAT is 62% on room air. Now, he has poor perfusion. His pleth is a little bit variable, so we're not certain about the value of that SAT because the pleth is in and out and very variable. And his skin is cold and clammy, and his extremities are cyanosed. But he looks like he's in shock. We're sure he's in shock. He has a gallop rhythm present, and he has bilateral diffuse crackles. Take a look at his EKG, no question. By the way, immediately, STEMI alert is called and cath lab is notified, and we rush this patient to the cardiac cath lab. But when you're looking at this EKG, it might be quite hard for you to actually evaluate it because it looks so bizarre. But what he has is what we call the traditional tombstone ST segment elevation all across the whole anterior wall involving the lateral, and with reciprocal ST depression in 2-3 and AVF. So he is having a massive anterolateral myocardial infarction with tombstone ST segment elevation, rushed to the cath lab, got on the cath lab table almost immediately. And this is just a visualization of his chest. Now, chest x-ray was done in the cath lab. We didn't wait for that. He was rushed off to the cath lab. But one of the things I want to note here is what we call his curly B lines. And that means that he's got lines of vascular engorgement that start really at the center and move out to the peripheral area. And he also has a very large looking heart. So that kind of brings us to our expectation when we're looking at patients like this, recognizing heart failure to cardiogenic shock, and really understanding and appreciate the common components of heart failure to cardiogenic shock. Most importantly will be MI and significant myocardial reduction in terms of ejection fraction or filling capabilities, severe dysrhythmias, severe valvular dysfunction, and of course, ultimately, a poor forward flow. That's your cardiac output or your stroke volume, with a high presence of volume in your veins. So venous volume overload, arterial volume underload. And of course, as that relates to arterial volume underload, there's a significant reduction in the delivery of oxygen to the tissue. The patient will have a significant base deficit. Remember, as base is in deficit, acid is always up. And typically patients will have elevated lactate. And lactate donates the metabolic acid hydrogen ion. That's what promotes metabolic acidosis. So base deficit's low, lactate is elevated, and we now say he is in lactic acidosis. So when we're evaluating a patient like this, as we as the bedside providers, the first patient who's seen the patient, or we're looking at him during our time with him when he's in our ICU, we're really going to look for signs of heart failure, signs of tamponade, cardiac dysrhythmia. But our biggest focus, and what's really going to bring us forward, is persistent tachycardia, tachypnea, shortness of breath. If we put our stethoscope on our patient, what we're going to have is muffled heart sounds, because those sounds have been distorted because of the amount of volume engorged inside the ventricles, so the heart sounds will get muffled. We also often will hear a third heart sound. Remember, that's an early sound, sounds like lub dub, but it happens early during diastole. So 1, 2, 3, 1, 2, 3. I think people used to say Tennessee, Kentucky. I don't know which one, never made sense to me. It's really 1, 2, 3. Because the fourth heart sound occurs just before the first one. So if my patient has a heart rate that's slow enough that I can hear lup, dup, dup, pause, lup, dup, dup, and he's tachycardic, so it might be lup, dup, dup, lup, dup, dup, lup, dup, dup, lup, dup, dup. And it's going to be hard for us to diagnose whether that's a third heart sound or fourth heart sound. If we can't do that, we'll just say extra heart sound. Our sound is different than a murmur because it sounds like lub and dub, and it really is about the movement of volume. Now, the neck veins tend to be very engorged, and so we see a high presence of veno volume, but also arterial hypotension. So a high volume load in the vein and a low volume load in the artery. Patient will also typically be very short of breath, as I mentioned, and frequently you're going to see bilateral edema in the dependent extremities, so both the feet and the ankles. Now, key terms for us to remember when we're evaluating someone in cardiogenic shock, when we're talking about utilization of mechanical circulatory support, a couple of very important key terms. Cardiac output, which is stroke volume times heart rate. Remember that cardiac output is looking at the amount of blood the heart ejects over a minute's period of time. So in terms of value, it's actually looking at an average of blood flow dynamic. So it tells us about whether or not the blood flow dynamic is adequate. But what's really important is the efficiency of ventricular ejection. Efficiency of ventricular ejection is evaluated by an echocardiogram or a point of care ultrasound to try to propagate and understand the ejection fraction, which is the percent of ejection from the amount of volume that has filled the ventricle. Percent of that volume ejected from the amount of volume that's filled the ventricle. Normal ejection fraction, 50 to 75%. Typically, these patients have a low ejection fraction. Now, it takes a lot of time to get an echo. It takes some expertise. So the next best thing is using whatever tools we have. If we have a ClearSight, if we have a FlowTrack, if we have a Starling, that we're going to, a Pico or a Lidco, we're going to evaluate our patient's stroke volume, which is actually evaluating the amount of blood ejected by the heart per beat. That's a really meaningful component when we're talking about somebody in cardiogenic shock, as well as evaluating a patient who has a mechanical circulatory device in order to determine whether or not we have actually supported the volume being ejected from the heart with each beat. After that, we talk about preload, which is the volume of the blood in the ventricles at the end of diastole, and it's about the compliance of the chamber and the amount of volume in it. And afterload, which is the resistance the ventricle must eject against. And typically, and in this case, we're really talking about left ventricular afterload, or what's known as systemic vascular resistance. So I made a very simple drawing. I'm a simple girl. I'm not an artist, so it is really simple. Just to remind ourselves that we talk about systemic and pulmonary circulation. Pulmonary circulation, the evaluation of the resistance in the pulmonary circulation is pulmonary vascular resistance. That's typically less than 250. The evaluation of the tone of the pulmonary artery is the mean PA pressure. The right ventricle is ejecting into that pulmonary artery, and it does that through right ventricular stroke work, or also a new terminology known as PAPI, Pulmonary Arterial Pulsatility Index. It's not written down there for you. And actually evaluating the filling of the right ventricle by CVP. So filling, work, tone, resistance. Same thing on the left heart. The filling of the left ventricle is evaluated by pulmonary capillary wedge pressure if you have a PA catheter, or PAD if you have a PA catheter. And if you don't, it's just going to really be evaluated by the presence or absence of fluid in the interstitium in the pulmonary bed. You can see it on a chest x-ray, or you can hear it with your stethoscope. Left ventricular function is left ventricular stroke work. Also, the newer methodology of evaluating the left ventricular function is cardiac power. It's a calculation. So cardiac power index for the left ventricle, which tells us about left ventricular work, the ejection of the left ventricle in the systemic arteries, and the measurement of that vascular tone by mean arterial pressure. And of course, the calculation of the resistance, which is the SVR. So resistance, arterial tone, work of the ventricle, and the filling pressure. So you've got those four categories for the left heart and the same four categories for the right heart. Very important for us to appreciate and understand that and separate that when we're evaluating our patients. Now, a patient who has a cardiac deficiency, really, really important to understand that when their stroke volume is inadequate, can't deliver appropriate oxygen, they're going to have a very significant compensatory mechanism response, all designed to improve the delivery of oxygen to the tissue by increasing the cardiac output. So there's really 5 major effects, and we look at all of them. Maybe we aren't thinking about them separately, but we're looking at all of them when we're evaluating patients who are in cardiogenic shock. So number 1, sympathetic nervous system discharge. Number 2, neurohormonal response. Number 3, dilation of chambers of the heart. Number 4, hypertrophied muscles. And number 5, the release of natriuretic peptide hormones. So really, really important when we're talking about these compensatory response. Now you can see this response has a lot of patterns behind it. Okay, so first and foremost, any person who is in cardiogenic shock is going to have a high activation of their sympathetic nervous system. Now, you know that because you look at them at the bedside and you see they have an increased heart rate. What you also hope is that they have an increased contractility, but increasing their contractility requires that they have a functional myocardium. So what you might see is an increased heart rate. And you have to say, when the heart rate is increased, I have an increased sympathetic nervous system stimulation. Now, what is going to happen with that increased heart rate, possibly the increased contractility, is that the patient is going to have a significant increase in his workload. And as he works more, he's going to have more oxygen demand at the myocardium. And because of that, what you're going to start to see is alteration in the functional unit of the myocardium, the myocyte. You're going to see that the patient's going to have some dysrhythmia, and you're going to see that he impairs his filling, diastolic, and ejection, systolic function. In addition to that, very common, always think about this because it's not going to flower immediately. It's going to be a slow grower over the next 24 or 48 hours. Is that the blood flow to the kidney is going to go down. That's one of the first things that happens when you have sympathetic nervous system discharge. That means that the kidney itself, at the filter of the kidney, the glomerulus, will release a hormone known as renin. Renin converts into angiotensin and aldosterone, which then promotes very significant vascular resistance and water and salt wasting. So really important to understand that when I see that persistent tachycardia and tachypnea in a patient who I think has some cardiac dysfunction, they are immediately threatening their kidney, even though you might not see it. Okay. And neurogenically, we're also going to see some vasoconstriction. And that's also quite important because, of course, that's going to limit oxygen delivery. The neurohormonal response, it's a big one. It's a lot to talk about. It could be a lecture all by itself. But just what I want to remind you is that when blood flow goes down, because I have a reduction in my cardiac output and a reduction in my stroke volume, the first thing that's going to happen is the release of renin, which converts to angiotensin and then stimulates the release of aldosterone. That's going to promote more salt and water reabsorption, meaning that my patient now is going to get volume overloaded. They're also going to vasoconstrict their arteries. So all of a sudden now I have an increased volume in my vein, but I have arterial constriction. So the volume in the vein not delivered necessarily to the arteries. And what I might see initially is an increase in blood pressure, but ultimately I'm going to see a reduction in blood pressure. The other thing, remember what we talked about was with that neurogenic vasoconstriction, that you're going to have a significant reduction in cerebral perfusion. And so what will happen because of that reduction in cerebral perfusion is your posterior pituitary gland is going to release antidiuretic hormone, also known as vasopressin. And that antidiuretic hormone is going to stimulate more reabsorption of fluid, meaning my venal volume overload will go up, 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 up. My interstitium is going to be overloaded, but I'm still arterially hypovolemic. Depending on the type of cardiac injury, you might also see what's known as a pro-inflammatory cytokine. Pro-inflammatory cytokines just stimulate an inflammatory response, and that is what plays a major role in the development of cardiac hypertrophy and actually promotes what one would call cellular suicide, that's known as apoptosis. So these pro-inflammatory cytokines that get released when we have a poor cardiac output and we have cardiogenic shock actually promote the suicide of your cardiac myocytes. Cells die before their time. That's called apoptosis. That's cellular suicide. Now, what actually happens and what we talk about, so we're standing at the bedside, we're seeing the patient's not making urine over the next 4 hours. He's starting to get fluid engorged. We can see his venous pressures are going up, his neck vein is distending, he's developing peripheral edema, he's hypotensive. We get an echocardiogram, and what we're going to look for in our echocardiogram is the very first thing that happens is that the patient will dilate their ventricular chambers. So what you see is very significant that you've got some dilation of the ventricular chambers and a change in way the septum separates the left heart from the right heart. So if this is a left heart failure, the septum is going to move over towards the right heart, making the right heart smaller. If it's a right heart failure, typically the septum is going to shift over into the left heart, making the left heart smaller. And then ultimately what happens is hypertrophy. Hypertrophy means that you have an increase in muscle mass of the heart. Now that sounds really good. That sounds really good, because a hypertrophic ventricle is going to create and generate more contractility and better stroke volume and better cardiac output. But that's not going to persist, because that hypertrophic heart is going to need a lot more oxygen. It also has some dysfunctional tissues. So you may have a hypertrophic tissue that doesn't participate in contraction. And so what ultimately happens is that hypertrophic ventricle is not going to fill very well, and it's not going to eject appropriately. So you're still going to have a reduction in your cardiac output. Last but not least are the natriuretic peptide hormones, and there's a lot of them. So typically we start with just talking about atrial natriuretic and beta type natriuretic peptide hormones. These are hormones that are released from the myocardium itself. They're produced primarily from the atria, secondarily from the ventricles, that whenever you have a patient, right, who has an increased volume load, they're going to release ANP and BNP. ANP and BNP actually promote, ultimately are going to promote diuresis. So that's fantastic. Isn't that fabulous? But in order for them to promote diuresis, they must actually be delivered into the kidney. And so what actually happens is that when we talk about poor cardiac output, we actually are releasing the hormone, but it isn't actually reaching the kidney. We don't actually see diuresis or natriuresis. And what actually happens is that BNP and ANP continue to go up, but without responsiveness. And of course, that's what we use whenever we take a look at your BNP. And there's pro-BNP, there's sodium pro-BNP. There's a lot of different BNP levels that we measure. Just in general, what we say is a BNP level greater than 100 is indicating to us that we have a patient who has heart failure, and the higher that level, the worse the heart function is. Okay, so now we just bring that to basically saying that cardiogenic shock is all the things we've already talked about, everything we've just talked about, which is myocardial dysfunction, both in contraction and in filling, volume in the vein, inadequate volume in the artery. So you have high venous pressure, low arterial pressure, but it's the arterial pressure which promotes the perfusion pressure in the coronary arteries. So since I'm hypotensive, my coronary perfusion pressure goes down, and I propagate more ischemia, and I have progressive myocardial dysfunction, which ultimately will lead to death. So really, really important. Everything I talked about is what ends up happening here. And this is really your basic spiral of inflammatory response, the inflammatory cytokines, which promote apoptosis, a production of intrinsic nitric oxide synthase, which promotes vasodilation. And that means as I promote vasodilation, I'm asking for the heart to fill the vessel more significantly. Typically, it can't do that. Patient may have very significant problems. So let's think about that as it relates to our physical exam. Cardiac output is low. Great if you can measure it, great if you can measure stroke volume, great if you can measure SpO2, but if you can't measure any of those things, you're going to assume it by cold extremities, distant pulses, metabolic acidosis, okay? So first and foremost, our first evaluation is you have low cardiac output. Your cardiac output is down, your extremities are cold, your pulses are distant, you're acidotic. Do you have volume, yes or no? And the way I'm going to know whether you have volume, yes or no, is that I'm going to look really generally. I'm going to look at your neck veins and your chest x-ray. I have nothing else. Let's just say I'm evaluating you in the ECC. You've just gotten in there. I have no lines. I have no catheters. I'm just going to evaluate. Obviously, your extremities are cold, but your neck veins are distended. You've got volume, but it's in the wrong space, okay? So typically, when we talk about hypovolemia, neck veins are flat or they're absent, and the patient's quite tachycardic. But when we're talking about cardiac failure, the neck veins are usually distended. They can have very enlarged veins elsewhere, and they can have volume extravasation in other places. So remember, for cardiac shock, we say poor blood flow and lots of venous volume, poor arterial volume, lots of venous volume. Okay. Now, if I can calculate SVR, I calculate SVR by saying MAP minus CVP divided by cardiac output times 80. Nobody cares because all your equipment calculates. You don't really need to calculate it. You're just saying mean arterial pressure minus mean filling pressure divided by cardiac output, and 80 converts it into dynes. So typically, early on in cardiogenic shock, our patient actually has vasoconstriction. That's why he has cold extremities and distal pulses, because he's vasoconstricted. But later in shock, what's going to happen is that he is going to reduce his vasoconstriction. He's going to be unable to maintain the adequacy of his vascular tone. That's a much later sign in shock, and that's when they really become hypotensive. So as your patient gets more and more hypotensive, their condition is getting worse and worse and worse and worse. So remember, it's really valuable if I can do an echo. It's really valuable if I can draw a venous sample from a central venous catheter. That would be from the distal port. That's typically brown. Send it off to the blood gas lab. I need a venous sat, I need a venous PO2 from the blood gas lab, from my venous straw that came from the brown lumen of the CVP catheter. They're indirect, but they can give us a lot of information. And again, one of the most important things you can do is measure a BNP. Wherever you work, measuring the BNP is going to tell you about the level of failure. The higher the BNP, the more you're releasing the hormone, but you're releasing the hormone without having the expected response, which is diuresis and natriuresis. So the hormone continues to go up because you're not having the response that you need. And that is a very significant heart failure indicator. Now, if we just talk about the New York Heart Association correlations, very simple, not requiring anything other than good cognition. We're just saying we're looking at congestion and perfusion. Congestion, venous; perfusion, arterial. Signs of congestion: distended neck veins, ascites, edema. Sometimes you'll have rales, depending on if it's right or left heart. And if you have rales, you might have orthopnea, meaning you need to sit up all the time, and PND, meaning when you lay down at night, you wake up short of breath. Okay. Evidence of low perfusion, pretty straightforward. Altered mental status, you're redirecting blood flow away from the brain, or you don't have adequate brain blood flow. Low serum sodium because you're quite dilute. Narrow pulse pressure, which is systole minus diastole, which trends with your stroke volume. Cold extremities, patients may be hypotensive. They may also have ACE inhibitor on board, and that could make that worse. And of course, renal insufficiency. So these are our signs of congestion and low perfusion that we're going to correlate together. And we look at this little quadrant approach, which is really simple, right? So if you have low perfusion, your extremities are going to be cold. But if you don't have congestion, your lungs and your neck veins are going to be dry. That's the most uncommon form of heart dysfunction that you see in patients. This is the normal heart. No low perfusion, no congestion, patient's warm and dry, doesn't have heart failure, doesn't have shock. Here are the two categories that we look at. So heart failure score 2 to 3, heart failure 4 is cardiogenic shock. So heart failure 2 to 3, the patient is warm. That means he's got perfusion, but he's very wet. He has high venous volume loads. And from here, patients rapidly progress to this cardiogenic shock, where they are cold, meaning hypoperfused, and wet, meaning they have venous extravasation of volume. Wet means venous extravasation, cold means poor perfusion. So if we look at these two categories, that makes up 90% of the patients that we see who come to our emergency department or who reside in our ICU who actually have heart failure. So now, in Barbara's simple way, I just want to remind you, your deoxygenated blood filling pressure is up, 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 and you have evidence of volume extravasation. That's right heart, wet system. Now, if your filling pressures are up and you have engorgement in your pulmonary vessels, that's your oxygenated blood. And so that means that in your pulmonary venous system, you're very engorged, you have extravasation of volume, you have pulmonary edema, okay? Filling pressures up, your patient has evidence of volume extravasation. Lungs are wet, system is wet. Both don't have to be, one of them does. Lungs are wet when you have left heart failure, system is wet when you have right heart failure. Arterial pressures are normal to down, and there's evidence of arterial hypoperfusion, meaning your extremities are cold, you have a base deficit, you have metabolic acidosis. Arterial pressures normal to down, evidence of arterial hypoperfusion. So when we're talking about the left heart ejects into the systemic arteries. So we have decreased organ perfusion, sign of organ dysfunction, and a cold periphery, hypotension in the systemic artery. If we really can't measure the effect on the right heart without looking at the pulmonary arterial waveform or the pulmonary artery pressures. So you really do need a PA catheter to diagnose fully right heart dysfunction. Okay, now I love this visual. I've done a little bit of modification to the visual just to remind you that a really important thing is to look at the filling of the right heart and the ejection, which is the stroke volume. So CVP to stroke volume. And what you're looking at here is at a relatively low CVP, you have a very beautiful cardiac output. And as I give you volume and more volume and more volume, you actually see that the heart is able to accept that volume and improve the cardiac output. That's gorgeous. When we talk about an acutely damaged heart, and that's really what we want to think about, is an acutely damaged heart at much higher filling pressures. So this is true right atrial pressure. So we look at CVP, so we're going to add around 2 to 4 to that measure. But you can see that you have to have a much higher filling pressure to have an ejection, and that ejection is really poor. Okay. Now, sympathetic activation, if I've got good sympathetic activation, I'm going to shift that curve up a little bit so that at a lower CVP, I still have a relatively good ejection. And then at this perspective here, where the heart is starting to recover at a much lower CVP, I have a better ejection. So let me make sure you appreciate, you do need to look at CVP. You always look at CVP to stroke volume. That tells you if you filled the heart and if the heart can eject. That's all you're going to do. Does filling get ejected? Does filling get ejected? That's really what you have to do. That's the Frank Starling modification. It helps us to evaluate whether or not you have effective cardiac function. So when we think about taking all this data, all this assessment capability, we're going to define shock in a very particular way. You have hypotension with systemic arterial pressure less than 90 millimeters of mercury for greater than 30 minutes, right? It's not incidental. It doesn't go up and down just because I turned you on your side or you sat up. It stays for greater than 30 minutes at less than 90. If you are able to monitor cardiac output and therefore cardiac index, which is calculated, if cardiac index is less than 2.2 liters per minute, or if your stroke volume is less than 40 mLs per beat. And if you have evidence of volume extravasation into the interstitium, and you look at a wedge pressure or a PAD greater than 18 or a CVP greater than 12. So we're really going to be on top of this when we're evaluating our patients. And then we're going to correlate that all together with indications of hypoperfusion of your end organ. So neurologic is typically restlessness, agitation, confusion, cold cyanotic extremities, reduction in urine output, some things that we're not going to really see immediately, like reduction in liver function, reduction in mesenteric blood flow and mesenteric function. We're not going to see those immediately. We're going to immediately see changes in cerebral perfusion. That's one of the best signals that we've got a patient who is in shock. Another really important signal is, of course, the thing I love the most. I love to talk about it. I love to measure it. I love to look at it. I love to try to treat it. And that's going to be your base deficit. So always remind yourself that when base goes into deficit, metabolic acid is in excess. That's the way to think about it. Don't need to worry about Rome or anything else. When base is in deficit, metabolic acid is in excess. Metabolic acid, not CO2, metabolic acid. And that means that the base is more negative than -2. It might be -5, -10, -12, -15. And what that's really telling us about is the consumption of buffer to neutralize acid to try to return pH back to normal. That's what the base tells us. And it's such an important tool. So remember, again, we go back and we evaluate. Filling pressures up, evidence of volume extravasation. In the pulmonary vault, that's pulmonary edema. In the systemic vault, that's typically right heart dysfunction. And remember, our arterial pressures systemically, That means you have decreased organ perfusion, left heart failure, and I have to look at pulmonary artery pressures to really know about the right heart. Now, the first thing we're always going to do, even if it's just for a short period of time, is we're going to use drug therapy. And what we're really going to try to do, so it's really important to have a complete appreciation for what I'm going to say, which is I am going to do a pharmacologic impella. I am going to perform a pharmacologic balloon pump, whichever one is more common to you and you're comfortable with, just take that. And that means that, first of all, I want to reduce your volume with diuresis. I want to dilate your vessels with ACE inhibition. I want to dilate your vessels further with nitrates or nitroprusside or nasiratide, depending on your situation. For most of us, rarely does anybody use nipride. Most of us use nitroglycerin. Some people use Natracor, but most of us use nitroglycerin. I just wanted to say those others because we have people outside of Grady and I don't know everyone's practice, but our focus primarily in vasodilation will either be with nitroglycerin or with the calcium channel antagonist, that would be cardizem, to dilate the vessels. So I'm going to diurese you, I'm going to dilate you. I'm going to actually try to limit the effects of the systemic nervous system. And that's going to be most particularly related to heart rate. So I'm going to start you on a beta blocker. And remember, not the brand name, like low pressure and Coreg, but the actual, not generic, but the actual chemical name always ends with an LOL. So carvedilol, metoprolol, Enderol, you might still be using. All of those are beta blockers, and the design is to block the negative effects of the sympathetic nervous system. So that means I'm trying to reduce your heart rate. Okay, now you might say, and it would be right, wait a minute, if you reduce the heart rate, won't you reduce the cardiac output? Yes, you will, because cardiac output is heart rate times stroke volume. But the goal in using a beta blocker here is to reduce the heart rate to allow more time for the ventricles to fill and to reduce the myocardial oxygen demand. So we might be quite cautious, but we are typically going to start beta blockers in these patients who are relatively shocky because we really need for their myocardium to rest. Now, when I use the beta blocker, I'm blocking the sympathetic uptake and activation at the sinus node, so that decreases the heart rate. But there are no beta blockers that don't also reduce myocardial contractility. So you have to be very cautious here. So let's say your doc said, I want you to give metoprolol, we're going to give an IV bolus to the patient, going to get that heart rate down. And that's really great. Great, doc, I'm going to do that. But before I do, I need an A-line because I need to monitor the stroke volume. If I use the beta blocker and my stroke volume drops precipitously, my patient can no longer compensate now by increasing his heart rate, which means I've significantly and profoundly reduced his cardiac output. So beta blockers are beautiful and terrible, as are inotropes. Inotropes are beautiful and terrible. They're beautiful and terrible. Primary inotropes that we use, digoxin is not something we use in the ICU. No one really likes to use digoxin, but it's the only long-term oral inotrope that patients can take outside of the hospital. We're not going to use it by IV. What our first choice will be is dobutamine. And those of you who've been around with me for a while know that I always remind you that unless your patient has chronic heart failure, do not start dobutamine at 5. Always start low because you need to see how sensitive the patient is to the stimulation. Many patients do very well with 2.75 of dobutamine. They don't require 5. The other positive inotrope that we'll use is actually a vasodilating inotrope. So it vasodilates aggressively, and it supports inotropic activity minorly, and that would be milrinone. And for most patients who are in cardiogenic shock or stage 3 heart failure, just before jumping off in cardiogenic shock, you would see the utilization of both of these at the same time. Dobutamine is a pure inotrope, milrinone is a dilating inotrope, and milrinone has a profound effect on the pulmonary vascular circulation. So we love to use milrinone if we think you have right heart failure. So you have a high CVP, you have a poor right ventricular ejection, but your LV does not express venous engorgement. You don't have engorgement of volume in the pulmonary veins. You don't have pulmonary extravasation. You don't have pulmonary edema. That's really important. So it's the reason it's important is you're not writing the orders for these medications, but you need to appreciate what you're trying to achieve with the medication and how you're going to utilize that medication to get to the endpoint of what you want. The other thing is if we have patients who cannot tolerate ACE inhibition, we'll put them on angiotensin receptor blocker. Now, what the difference in this is that actually when we block conversion of angiotensin, that is done in the lung. And so oftentimes that can cause kind of a hyperinflammatory response to the lung. Patient develops a dry cough. That actually most people will say, oh, he's got an ACE allergy. He has a hyperinflammatory response when we are blocking conversion of angiotensin in the lung vasculature. The ARB blocks the receptor site for angiotensin. So it's blocking that actually at the kidney and in other surfaces in the vascular surface, but is not involving the pulmonary vasculature. And so we use ARBs for patients who present with angiotensin receptor, angiotensin 2 blockers, or the angiotensinogen blockers that actually block the conversion of angiotensin and who have some types of reactions in relationship to that. Okay, just as a reminder about our agents, so we just think about the sympathomimetic agents. Vasopressin is not a sympathomimetic. So sympathomimetic, mimicking what you have in endogenously in relationship to alpha-1, beta-1, and beta-2. So you can see that very straightforward here, that dobutamine is beta-1 greater than beta-2. Now, beta-2 stimulation can promote vasodilation. Beta-1 stimulation typically is heart rate and contractility. So lower doses of dobutamine in somebody who hasn't had heart failure, does not have known chronic heart failure, a very low dose in dobutamine can achieve a significant increase in contractility, a much better cardiac output, but may not actually increase the heart rate until you get to a higher level. Norepinephrine, as you know, is primarily alpha. Alpha is in the arteries. At higher doses of norepinephrine, above 20, you're going to start to see some beta-1 and beta-2 stimulation. So typically at higher doses of norepinephrine, you've got very significant vasoconstriction, but you now also have an increase in the heart rate. So those two things together will make your stroke volume go down. The majority of us don't use dopamine anymore. There's a lot of controversy about dopamine. Cardiologists really enjoy dopamine in general because they feel like that gives them much better coverage. Low dose dopamine typically supports some renal blood flow. A little bit higher dose of dopamine supports inotrope, and even higher dose of dopamine supports vasoconstriction and inotropic activity. Okay, same thing with epi, alpha-1 greater than alpha, or equal actually to alpha-2, beta-1 equal to beta-2. So really is dose related. At a lower dose, it's primarily beta. As you get to a moderate dose, 2 to 10, it's beta greater than alpha. And as you get to greater than 10, it's alpha. So if you're pure beta, you're going to have an increase in your heart rate and your stroke volume. If you're beta greater than alpha, what you're going to see is more significantly an increase in the heart rate, but not necessarily in the stroke volume. And once you get into alpha, more pure alpha, you're going to have vasoconstriction. Phenylephrine is something we in general, it doesn't mean never, that we in general do not use in the ICU unless you're in a neuro ICU, that's neosynephrine. But it is something that is used very aggressively when you have situational hypotension. Like you have anesthesia-induced hypotension, there's not a reason to start patients on norepinephrine. They're going to get boluses of phenylephrine. So as your anesthesiologist is bringing a patient to you from the OR, their presumption is that if the patient has hypotension, it's anesthesia-induced hypotension, the number one drug of choice for that kind of induced hypotension. Neurologic hypotension and anesthesia-induced hypotension is phenylephrine. And that's why they use boluses of neosynephrine as they are coming from the OR to you. They're given boluses of neosynephrine. And then they say, oh yeah, the blood pressure is fine. They go away and all of a sudden you plummet. Well, the neosynephrine is gone. And now we recognize that the patient actually needs support. In the ICU, the support we're going to typically give is norepinephrine, then norepinephrine plus epinephrine, or norepinephrine plus vasopressin. But I always want to encourage you to remember that if we're talking about cardiogenic shock, you might need to squeeze that low dose inotropic support in there if possible. Now, the thing that's really important, and I'm always so concerned that you hear me here, there are some really great things about inotropes and vasopressors. In a person with cardiogenic shock, you're going to have rapid improvement in hemodynamics. That means stroke volume, heart rate, and blood pressure if you use inotrope and vasopressors. Okay. Now, in general, in the first hours of cardiogenic shock, while you're trying to get all your ducks in a row and you're trying to make good decisions about what's going to happen next, in those first hours, inotropolus, vasopressor, and cardiogenic shock typically are going to outweigh the risks because any cardiac patient with hypotension is going to have limited coronary perfusion. So by the way, you've got to get them onto inotrope and vasopressor immediately. Stop all this crazy titration of norepinephrine and epinephrine not getting any better, not looking at what that patient's inotropic function is because they have cardiogenic shock. And just vasopressors alone are going to limit their stroke volume and it makes patients much worse. But I'm going to tell you that inotrope and vasopressor is part of a pharmacologic balloon pump or a pharmacologic impella. I don't want to use it for long because I want to move beyond pharmacologic circulatory support to mechanical circulatory support. And there's a lot of bad stuff when we use inotropes and vasopressors. First of all, the work of the ventricle increases. The oxygen consumption increases, which then can lead to increasing myocardial ischemia and ventricular dysrhythmias, hypertrophy of the ventricle, and expansion of the infarct. So I only want to do this at the lowest dose possible and for the shortest period of time, just supplying pharmacologic circulatory support until I can do something else. Now, anybody who knows me knows that I adore inotropes. I adore inotropes and cardiogenic shock, but I like that to be really, really cautious and at the lowest possible level. And that's because when you add an inotrope to someone who has cardiogenic shock without really paying attention to their mean arterial pressure, their aortic root pressure, which then affects their coronary perfusion pressure, you can actually cause a significant increase in the demand for oxygen, that's MVO2, myocardial oxyconsumption, at a time where they're already oxygen starved, where they might be hypoxic, where they have an occlusion in the coronary artery, where they are not supplying adequate oxygenated blood flow. That's very distressing. When your patient receives an inotrope, they're going to have tachycardia. And the worse the tachycardia, the worse the increase in myocardial oxygen consumption. So that's why I always want to start dobutamine or dobutamine plus milrinone same time. And I want to start with a very low dose because I do not want to see significant tachycardia. Frequently, when you start at 5 patients tachycardic right away, you've already extended their infarct, you turn the dobutamine off. Now you've lost the chance to use that at a lower dose. So it's always a good discussion. We don't, in general, nurses do not have the autonomy to titrate dobutamine, nor should they. We should have a discussion with our physician, say, I'll start at 1.25, move to 2.75, then to 3 or 2.5, and then to 3.75. And I'm going to monitor the tachycardic response. If tachycardia increases, I'm going to stop going up on the inotrope, so that you're really giving them an idea of what it is you want to do by starting low. You're monitoring the tachycardic response. Once your patient starts to have tachycardia, you cannot go up on inotrope anymore because it increases myocardial oxygen consumption and it puts the patient at significant risk for myocardial ischemia. Now, the other thing about tachycardia that's really vitally important is to remember the faster the heart beats, the less time you have to fill your ventricle with volume. That's the diastolic interval. That's when your ventricle fills with volume. So the faster the heart beats, the less time you have for filling. That's going to affect your stroke volume and it puts your myocardium at risk. Okay. Because of that tachycardia and the decreased diastolic interval, you're going to have some problems filling the ventricle. So that causes your filling pressure to go up and extravasation of volume in the pulmonary vault and in the systemic vault. And the other thing is that sustained tachycardia. This is all about tachycardia with inotrope. So that's why lots of times people like milrinone better because you don't really have much tachycardia with milrinone, but it's such a weak darn inotrope. So the thing is to combine milrinone plus dobutamine, which can give you a much better effect. Okay, the other thing is that tachycardia enhances cellular suicide. Remember, that's apoptosis. That means the myocytes are killing themselves, and that's going to, of course, decrease myocardial recovery. So there are a number of different devices. I'm really going to only talk about 2, okay? But beautiful, ECMO, fantastic, and this is a CardioSave. Tandem heart, fantastic. Cardiac transplant, fantastic. Resynchronization therapy, fantastic. I'm really just going to talk about 2 things today: balloon pump, and only very quickly and the Impella device for the left heart, the 2.5, which most of us do not use, the CP, which is has flows up to 3.7, and the surgically inserted Impella 5.0 or the newer version 5.5. So Impella is overall, ignore that CP, overall is named by the amount of blood flow that it supports. So this is Impella-induced blood flow. And then you can also have native heart blood flow. So if my native heart has a liter of blood flow per minute, when I add an Impella 2.5, they're going to achieve about 3.5. If my left heart has no blood flow when I put them on a CP, they're going to actually achieve an Impella blood flow rate of around 3.5. Now, once I have Impella on board and I know what the flow rate of the Impella that I'm using, so again, here at Grady, we use the CP, which is typically around 3.5, and we're going to start using the 5.0, and I believe we're going to use the newer 5, so that will be 5.5. That means my expectation is that if you have adequate volume and your Impella device is in the correct position, you're going to have a blood flow equal to the name of the Impella, 3.5, 5.0, or 5.5. You don't have blood flow equivalent to the name of that Impella, I probably don't have adequate volume. I probably have too much vasopressor on board. So not enough volume, too much vasopressor is going to limit that. Okay, really, really important when we're thinking about mechanical circulatory support. So what I want you to see here is balloon pump, Impella, tandem heart, and ECMO. Now, right now, we're not doing ECMO. Even when we do, we won't be doing VA ECMO, at least not initially. I just love this, though, because it compares the cardiac flow. So I want you to see what the balloon pump does. Balloon pump does not actually support cardiac flow. This is actually at 0.3 to 0.5 liters per minute. I can do better with inotrope. Okay. The Impella, though, is supporting your blood flow dynamic 1 to 5 liters. Now, remember, Impella 2.5 is going to support it around 2.5 liters, Impella CP at around 3.5, and Impella 5 at around 5 liters, Impella 5.5 at around 5.5 liters. So that means I'm basically supporting your whole heart. When I give you an Impella 5.0, it's almost like having a cardiac transplant because you're getting 5 liters of blood flow. Okay. Balloon pump resides in the aorta, but the tip of the Impella resides in the LV. The input, meaning sucking blood out of the LV, is from the LV, and then we output it into the aorta. So the Impella resides across the aortic valve from the LV to the aorta. Okay. Now, balloon pumps can stay in for weeks. What is actually supported by the FDA is 7 days of Impella, but many of us use Impellas for 2 weeks. Lots of patients have Impella plus ECMO, and they're on that for a month. So FDA is cleared for 7 days, but we're all doing what we think is best for patients. And we may not always have evidence behind it, but that's what we do. Okay, so just talking about sheath size, so you can see 7 to 8 French, and this is much more significant, 13 to 14 French, right? And putting it in the femoral artery size as 4 millimeter size that we're going to place into the femoral artery. And then we're looking at these much greater size. So here's one thing I think is really important. You've got to have a cardiac rhythm, and it needs to really be stable, relatively stable, for a balloon pump to work. I don't care if you don't have a cardiac rhythm at all. You can be asystolic when you get an Impella. Now that's really important because many of our patients actually have no rhythm or very little rhythm, and they can get an Impella, and the Impella will flow blood. Now that's not going to persist for a long period of time, but it's really important because down in the cath lab, they'll place an Impella in somebody who's in frank shock and cardiac arrest. They'll place an Impella, and the patient will have blood flow, but he won't really have an electrical heart rate. So really important to compare balloon pump to Impella. Got to have a heart rate for a balloon pump. Don't have to have a heart rate or a stable rhythm. I mean, it's helpful to have one, but you don't have to have one with your Impella. Now, that's not forever. That's just short term. They both reduce resistance load to ventricular ejection, but the Impella significantly and profoundly, almost universally and unilateral, increases MAP. Now, you remind yourself that the balloon pump increases augmented diastole and reduces diastole, so you get a wider pulse pressure and a better MAP. Impella is MAP only. It's not systole and diastole because it's not pulsatile. Balloon pump is pulsatile, Impella is not. So we really are just focused on MAP with Impella. Very significant increase in cardiac flow, very significant increase in cardiac power, and look how well it moves that volume. So volume leaves the vein, fills the ventricle, and is shot out. So it's sucked from the ventricle and shot into the artery. It's a really beautiful deal. Both of them increase coronary perfusion, and balloon pump can, if timing is right, decrease myocardial oxygen demand, but with the Impella, you can have a profound, significant decrease in myocardial oxygen demand with an increase, of course, in both with aortic root pressure and coronary perfusion. Not going to talk about those two, really just talking about balloon pumps and Impellas. Now, I just want to look at, again, the most important thing here, which is balloon pump requires a stable rhythm. Impellas do not require a stable rhythm. For the right-sided Impella, it's very helpful to have a stable rhythm, but it's okay if you don't. So just look at your blood flow dynamics. So 2.5, 3.7 to 4, that means in association with patient's native heart function, 5 and 4 liters of blood flow. Okay, and just remember, with the balloon pump, you hardly get any blood flow support. That's why a lot of people today will choose Impella versus balloon pump, because even though the balloon pump unloads the heart in terms of afterload and afterload reduction, the Impella actually improves blood flow dynamics. So preserves your organs, actually puts you in a much better state to survive, and much better and much more effectively. Okay. So lessons learned here with axial flow pumps. In cardiac arrest with a CP of 5, 5.5, patient may have asystole and no pulse, but he has a normal cardiac flow. His cardiac flow is going to be evaluated by his MAP. So if you have an MAP, but you don't have an electrical rhythm, do not perform CPR. Okay? Do not perform CPR. Okay? If you don't have a cardiac rhythm and you don't have adequate flow, you turn your device down to P2, that's perfusion 2, and begin CPR. But you never perform CPR if your patient's got an adequate flow. And adequate flow is considered anything above 2.5 liters. Okay. If you have an RP and you have a cardiac arrest, you're going to turn down your pressure, your perfusion rate to 2, and that's actually the rotation of the motor in the Impella, and you're always going to begin CPR. But just make sure there's no flow before you begin CPR. You want to be sure the patient's not having flow when you do CPR. With the left-sided Impella, you can have flow and no electrical rate, but with the right-sided Impella, you really do need to have an electrical activity to have a blood flow dynamic. So lots of conundrums educationally about when do you do CPR. So again, with left-sided support, if you're an AFib, VFib, VTAC, get the rhythm under control, give medication, do a shock, whatever you need to do. But if you got flow greater than 2 and an MAP greater than 65, even if you're in VFib, VTAC, severe AFib, supraventricular tachycardia, don't do CPR, just fix electrical. Don't do CPR. But if you have flow that is not responsive and has not been responsive, volume inotrope vasodilation, flow is less than 2, MAP is less than 40, you've got to begin CPR. So you turn your your pressure, the P value, the pulsatile value, that's what I was looking for, down to 2, and you initiate CPR. That's really the evidence of that conundrum. So just remember about intra-aortic balloon pump, and what's so important about the balloon pump is that it is timed to your arterial pressure, and it is triggered by your electrical activity. So very important to remember that electrical activity is really important for good intra-aortic balloon counterpulsation. But in the shock trials, in shock 1 and shock 2 trials, so shock 2 trial was published, I think 2016, maybe 2017, it actually supported exactly what you see here, which is there is no hemodynamic benefit in intra-aortic balloon pump. Okay, and really looking most particularly at cardiac power output. So what you can see here with the balloon pump is that you don't really increase cardiac power, which tells you about native heart recovery and cardiac function and cardiac work. And without the balloon pump, your patient actually did better. So really important to just remember, we're going to use what we have. We're happy to use a balloon pump if that's what we have and that's all we have. That's what our doctor ordered. We're going to do our very best to time with it and utilize it appropriately. We're just going to remind ourselves that balloon pump doesn't really promote cardiac rest, and it does. Cardiac rest, not arrest, cardiac rest, and it doesn't promote enhancement of cardiac flow. The Impella, though, is actually a flow device. So inflow, sucking blood from the ventricle and ejecting it. In this case, we're talking about a CP or a 5.055 Impella, suck blood out of the left ventricle and eject it into the aorta. And this little line right here actually helps us to define the placement of the catheter because it crosses the aortic valve and resides, the end part of the device resides in the aortic root. So I take all that volume from the vein and move it into the artery. Okay, so this is end diastolic volume, end diastolic pressure, and this is aortic pressure. So I take the volume from the vein and move it into the artery, and I do that via blood flow. That means that the oxygen demand goes down and the oxygen supply increases and the power of the cardiac function improves. So this is fabulous. It's such a wonderful and profound methodology. So just to introduce you to Impella, just to remind you, I'm really here talking about left-sided Impella, that Impella's CP, which is 2.5, and CP 3.5 and the 2.5 Impella. These are placed percutaneously. They are placed in the cardiac cath lab and they're placed under fluoro. The surgical cut down, which would be the 5.0 and the 5.5, have to be placed in the OR, and that's that surgical cut down state. So let me just stop sharing for 1 second. Reshare. And just for those of us who use Impella, but maybe don't use 5 or 5.5, you can see that this actually is cannulating here and actually goes into the aorta and the left ventricle. Okay, so it's cannulated externally, and this is a beautiful position. It's a good position. This sidearm, the purge sidearm, that's more about how we use our Impella, but I just wanted to show you a good position of cannulation and the external fixation for the Impella 5.5. Okay, so let me go back to share screen and go back to my slides. Okay, so again, we're looking at that Impella family, 2.5 CP5 and 5.0, 2 RP, lots of differences between them that we've already really covered in terms of their size, their flow dynamics, and what they're able to do for us. When we look at our Impella console, so this is an older console, we have a little bit different console now, but this is still such a great way for us to look at this patient. So what we're looking at is this is called the placement signal, and the placement signal looks at the difference in pressure between the ventricle to the aorta. This is ventricular, this is aorta, ventricular, aorta, ventricular, aorta. And you look at that placement signal, it's similar to, should not be used in replacement of, but similar to arterial pressure. Down here, you're looking at the flow. So the max flow that you're achieving with your Impella is 4 liters and the min flow is 3.1. So the average flow is 3.5. That's gorgeous. This is a CP. This is fantastic, fantastic. Okay. Motor current shows you how aggressively the motor is actually turning. This is an Impella, which sucks the blood, pulls the blood from the left ventricle and shoots it into the aorta. And the motor current tells you about how effectively that motor is turning over and how hard the motor is working to pull blood from one chamber to the other. So those are really the perspectives. We think about this Impella. Here's your Impella. This is a CP. And you can see your Impella tip right here. And I can't really see where we are in terms of the aortic valve because I don't think I have enough light. I'm so sorry. When we place the Impella is off and we look at microcirculation in the sublingual bed. That's really one of the best places. We don't have an Impella on. What you see is this kind of sludgy, really poor blood flow here. And when we turn the Impella on, 48 hours after Impella is turned on, look at the blood flow dynamic and the sublingual circulation. Now, if you don't know about sublingual circulation, that might not be that important. This is what my sublingual circulation looks like. This is what your patient cardiogenic shock sublingual circulation looks like. When we put them on Impella and we leave Impella on board, they're going to achieve better blood flow dynamics, and they're going to return their circulation more to normal. Okay, so let's take a quick case, really quick. All right. So 51-year-old man wakes up with chest pain, shortness of breath, calls 911 hospital triage system. This is actually not my patient. This is one of my colleagues' patient from England. So their call is 112. EMS calls, they send the EKG, he's abnormal and he looks in very poor clinical condition. He's brought to the hospital and cath lab's notified. He gets aspirin, basic Plavix, heparin, and oxygen. His condition on arrival, severely distressed and restless, pale with cold, discolored extremities, blood pressure 60/40, heart rate 104, SATs 81% with oxygen and 4 liters nasal cannula, breathing 30 times per minute, not intubated yet. Now he's in the cath lab and you can see he has no distal blood flow. Now here's the problem in the cath lab. When they actually inject that dye and they see there's no distal blood flow, opening up that vessel without support can lead to a rapid distribution of metabolic byproducts that can cause cardiac arrest. So the idea is when you see this as a cardiologist and interventionalist, you say, you know what, I better protect this patient by placing an Impella, because then if he has an Impella, I can offload his blood, whether his heart stops or not, I can offload his blood and protect his myocardium. Okay, so they immediately place an Impella CP and the patient immediately was less short of breath. Now he was very sleepy. So he said his pain was better. He was less short of breath and his blood pressure now is 80/70. He's not getting any vasopressors, no inotropes. Blood pressure came up, heart rate still 105. Okay, now look at that final result. So remember that occlusion now. We've got really beautiful, profound blood flow now through the left main, the LAD, and the left circumflex, where we had no blood flow before, and the patient is protected here with the Impella. And here's where their aortic valve is. So this is up into the aorta. Here's his aortic valve, and that's the marking at the aortic valve mark. Okay, immediately after PCI, going up to the ICU, or to the CCU, his blood pressure 95/85, heart rate is 100, SATs are 90%, some resolution on his EKG, never got inotropes, never got vasopressors, and didn't, in England, the sicker you are, you have to go to an ICU. If you're less sick, you go to the CCU. So he goes to the CCU. Now he has a very poor left ventricular ejection fraction initially, and this is immediately after PCI admission to the ICU. So he had a very high level of CKMB, and that's what they were looking at that time. So I'm going to correlate that to an HS troponin of around 100. HS troponin very elevated. And he initially had a high rise in his creatinine levels of CKMB and low urine production, but he restored that. Total CP support for 8 days in the hospital. He was weaned, discharged to the local hospital, went home a week later. Total admission time in the hospital was 19 days. Follow-up visit 4 months. Left ventricular ejection fraction 46%. Re-angio after 9 months to look for at the left main and to look at the left main PCI. Had great results. He resumed all his former activities without apparent limitations. Recovered patient, recovered heart. Really fantastic. A really wonderful methodology and really, really, really important for us to remember. So I don't want to share. I want it to stop. I'm sorry, I went back in there. So really fantastic when we think about methodology. So I'm just going to remind folks who don't know me, I began my career in 1976 at Massachusetts General Hospital. I was in a myocardial infarction unit. It was a very intensive cardiac unit. We placed balloon pumps at the bedside, and these were huge, and we had to do cut downs. We gave all our patients PA catheters. And our primary therapeutic regimen was a pharmacologic balloon pump, which was inotrope, vasodilation, diuretic, and possibly vasoconstriction, all 4. And then we would do a cut down and place the catheter for a balloon pump. And what we often would see in those days is pharmacologic circulatory support failed and balloon pump actually failed as well. And that's part of the evolution to Impella and ECMO, is that early recognition that we are not achieving the results that we want, that we don't have better blood flow, that we're not moving venous volume to arterial bed, that our stroke volume has not improved, that our cardiac index has not improved, that our urine output is not improved. Those things really require a vigilant nurse who's evaluating this at the bedside and doing it aggressively. Because if we fail to resuscitate with circulatory support and or with balloon pump, we have to consider what's next. What's next may be in your institution, VV ECMO or VA ECMO. In your institution might be tandem heart. In our institution and many institutions worldwide, it's the implementation of Impella. Problem, of course, for placement of Impella is if you're going to do it percutaneously, you've got to go to the cath lab. If you're going to do it surgically, you must go to the OR. We're not doing it at the bedside. We're not doing it at the bedside. I don't think anybody is really right now. And that's because you really have to have fluoro. And of course, you have to have an open chest if you're going to do it in OR. So that's really, really important. But I want to make sure we appreciate our role and responsibility is to recognize acute heart failure and cardiogenic shock as soon as possible, to implement strategies, place a central line, place an arterial line, implement strategies to improve cardiac ejection, to improve blood flow dynamic, to recognize that the combination of vasopressor and inotrope really puts the myocardium at risk. The bravest person in the world would like to do an inotrope with a vasodilator, but the patient may drop their pressure. If they drop their pressure, they're going to infarct their myocardium. So it's a very tenuous balance. And if they're not responding to pharmacologic circulatory support, we have to think about mechanical circulatory support. Historically, that was a balloon pump. We've had study after study after study that says balloon pumps do not improve hemodynamics and do not improve mortality. So for the majority of us, we are moving away from the balloon pump towards other methodologies of mechanical circulatory support. And the most recent shock trials show that early implementation of Impella can actually significantly, profoundly improve outcomes. All right, my friends, we've stayed together for a bit. I think we're at about 5 after 5, so a few minutes longer. I am so grateful that you joined me here today. Hope you've learned something meaningful. I'm very happy to continue doing discussions about balloon pumps and how to use them, and Impellas on how to use them. But first, you have to lay the foundation for us as bedside providers to recognize patients who are pre-shock and try to recover them before they've lost more myocardium. So hopefully you feel like you've learned something new today. I'm very grateful that you've attended, and I am going to say ta-ta for now. Tomorrow I'll be talking about monkeypox, and we've had 2 patients that I'm going to discuss very generically, that's for tomorrow, and then I'll send out the menu for next week. So thank you very much. I'm going to stop recording now, but I am going to be available to answer questions. Thank you.